people are there. Good number. Lucky number.
Since I will allow Rahul sir, he's waiting.
Good morning. Sandhya? Good, thank you.
Good morning, everyone. In this class, we'll discuss about the article mitigating the risk transfusion or reoperation for bleeding after cardiac surgery. In this class, we'll discuss about the study hypothesis, population, how are the patients selected in these groups are classified into 4 groups, and blood components transfused post cardiac surgery, and complications of blood transfusion, trolley, impact of reoperation and massive blood transfusion, and hemostasis, what all hemostasis checklist to be done before a sternal closure, and 5 minutes drainage assessment during wiring and closing the skin, what are the coagulation profile to be done and how to manage it and take and regarding the study findings. Introduction. Reoperation is a morbid event after cardiac surgery. Recent studies have shown that 2 to 6% of patients will be needing reexploration, and it is associated with 3 to 7-fold increase in operative mortality. STS includes surgical reexploration as a key quality metric, along with stroke, deep sternal wound infection, post-op renal failure, and prolonged intubation. Currently, blood transfusion is often done first, reserving re-exploration for refractory bleeding. However, blood transfusion carries its own risk like trolley, infection, and renal failure. Higher blood transfusion is directly proportional to the greater risk of complications. The study hypothesis, substantial transfusion without re-exploration and delayed re-exploration after transfusion may increase the morbidity and mortality, and it is worse than early guided reoperation before massive transfusion. The study population, the data from STS database was included. The included patients were isolated CABG, isolated mitral valve repair or replacement, isolated aortic valve repair or replacement, or any combination of above. The patients included are whose patients STS risk scoring was available and data on re-exploration for bleeding was available. So the total number of patients included in the study was around 23,000 to 40, and in that 2.2% of people underwent reoperation. The definition of substantial transfusion, according to this study, is based on a median transfusion in the explored group that is greater than 5 units of RBC or greater than 4 units of non-RBC products. In this study, patients are divided into 4 groups. Group 1, patients who underwent no re-exploration and no substantial blood transfusion. Group 2 patients underwent re-exploration without massive blood transfusion. Group 3 patients, their bleeding was managed only with uh, blood product transfusion without re-exploration. Group 4 patients, patients who underwent both massive blood transfusion followed by re-exploration. This chart shows the percentage of patients with reoperation for bleeding across the 10 centers in the state. These are the 10 centers, and in no maximum percentage of patients with re-exploration was 3%. Overall incidence of re-exploration, around 2% of the patients included in this study underwent a re-exploration. No hospital had a re-exploration rate of more than 3%. Characteristics of re-operated patients compared to non-re-explored patients. Re-explored patients were older, more dialysis dependent, more likely to have congestive cardiac failure, but Re-explored patients, as per this study, less likely to have diabetes and dyslipidemia, and they are more likely to undergo valve procedures, uh, less likely to undergo isolated CABG. Most of the patients fall under group 1, for whom no massive blood products or no re-exploration was done. Around 350 patients was included in group 2 and group 3, and in group 4 patients, around 167 patients were included, for whom both massive blood products and re-exploration was done. Okay. Preoperative differences. Group 1 patients, that is who didn't undergo any massive blood transfusion and re-exploration, were younger, less dialysis dependent, less incidence of congestive cardiac failure, more likely they are diabetic, and they are more elective cases, and more likely to undergo isolated CABG, and they are less likely to undergo valve procedures. So the this chart shows the amount of blood products transfused in all four groups. You can see in group 1 patients, almost no blood products was transfused. In group 2 patients, total units was around 5. In group 3 and group 4 received a massive blood transfusion. Around 16 products were transfused. Group 3 and group 4 had highest transfusion burden. Differences are also significant between group 2 and group 3, group 2 and group 4. Uh, these are the various blood components transfused during and post cardiac surgery. PRBC was transfused when there is less hemoglobin. FFP was transfused when there is any coagulation factor deficiency. Cryoprecipitate we transfused when there is mainly fibrinogen deficiency. Random donor platelet, 1 unit will increase the platelet count by 5,000 to 10,000. Single donor platelet, 1 unit will increase the platelet count by 30,000 to 50,000. Platelets are more prone for bacterial contamination because it is at room temperature. Transfusion reactions, and it is classified into immediate reactions and delayed reactions. The most common transfusion reaction is febrile non-hemolytic blood transfusion reaction. Other immediate reactions are trolley, allergy, and anaphylaxis. Delayed reactions, delayed hemolytic transfusion reaction, post-transfusion purpura, infections. Most common infection transmitted through blood transfusion is hepatitis C, although blood is screened for hepatitis B, C, HIV, malaria, and syphilis. Complications of substantial blood transfusion, other dilutional coagulopathy, metabolic acidosis, hypothermia, citrate toxicity. Citrate is the anticoagulant used in blood. Citrate toxicity will manifest as tingling and numbness. Hyperkalemia can cause arrhythmia and hypocalcemia. We'll see about transfusion-related acute lung injury. The definition of TRALI is development of respiratory symptoms within 6 hours of blood transfusion. Patient will manifest as dyspnea, tachypnea, and fever. These symptoms are difficult to differentiate from ARDS. X-ray findings are also similar to ARDS, that is bilateral whiteout appearance. Pathogenesis of TRALI is antibodies against human leukocyte antigen 2. TRALI is more common with FFP transfusion. This chart shows the patient and surgical characteristics by reoperation for bleeding. You can see the patient who underwent re-exploration are mostly elderly, and they are less likely to have diabetes and dyslipidemia. Patient who didn't undergo re-exploration, as per this study, are more likely to have diabetes and dyslipidemia. And re-explored patients are mostly dialysis dependent. They are more likely to have congestive heart failure. Isolated CABG patients are less likely to undergo re-exploration. but valve procedures like aortic valve, mitral valve repair or replacement had more rate of re-exploration. This chart shows the patient and surgical characteristics in all the four groups. We can see the group 1 patients who didn't undergo any massive blood transfusion or re-exploration are younger, and they are more likely to have diabetes. Group 4 patients are less likely to have diabetes, only 35% had diabetes, and they are more likely to be dialysis dependent. This chart shows the percentage of mortality in all the four groups. We can see the in group 4 patients, the mortality rate is as high as 19%, whereas in group 1 patients, it is only 1.5%. Group 3 and group 4 patients had almost similar mortality rate. So patients in group 4 had significantly higher risk of renal failure, stroke, prolonged length of stay, uh, and their 30-day readmission rate is also high, and they had reduced short length of hospital stay. Group 3 patients who underwent massive blood transfusion without re-exploration, and Group 4 patients who underwent both massive transfusion and re-exploration. These two groups had no significant difference as per the study. Um, this forest plot shows the difference between group 4 and group 1. You can see in group 4 patients, the odds ratio is 9. So the group 4 patients had 9 times higher risk of mortality when compared to group 1, and their readmission rate, prolonged hospital stay is high in group 4 patients, and the rate of stroke and renal failure is also high in group 4 patients. This forest plot compares group 3 and group 4. You can see there is no significant difference in both the groups because all the parameters here, the confidence interval crosses the one. So the mortality, readmission rate, length of hospital stay, stroke, renal failure, all are statistically not significant between group 3 and group 4. Impact of transfusion among reoperated patients. All patients in group 4 and group 2 underwent reoperation for bleeding. So when we compare group 4 and group 2, group 4 patients received substantial blood transfusion, whereas group 2 patients were re-explored earlier without having massive blood transfusion. When we compare these two groups, the renal failure rate, prolonged length of hospital stay, 30-day mortality is higher in group 4 patients. So the key message is even among patients who underwent re-exploration, receiving large volume transfusion independently increases the morbidity and mortality. This forest plot compares group 4 with group 2 patients for whom only re-exploration was done. You can see in this forest plot, group 2 patients has lesser rate of mortality when compared with group 4. And the group 4 patients had prolonged the length of stay, and they had high incidence of renal failure also. This chart compares group 2 and group 3 who underwent a massive transfusion without re-exploration. So in group 3 patients, when compared to group 2, rate of renal failure, prolonged length of hospital stay, 30-day mortality is more. So this forest plot again compares group 3 and group 2. We can see in group 3 patients who had a massive transfusion had high rate of mortality, prolonged length of hospital stay, and high incidence of renal failure. Optimal timing of re-exploration for bleeding. So the patients who underwent re-exploration yearly, that is within 24 hours, had lesser rate of renal failure, prolonged length of stay, and 30-day mortality when we compare the patients with whom we re-explored later. So the takeaway message is early re-exploration within 24 hours is associated with significantly better outcomes across all measures compared to delayed re-exploration. This is the hemostasis checklist we can do before wiring. Before wiring, we should check for the operative sites in CABG, mainly proximal and distal, conduit tributaries, side branches, cardiac chamber and great vessel incisions, and pacing wire sites, both atrial and ventricular. If it is on pump, we should check for cannulation sites and vent sites. And in mediastinum, we should look for any thymus vessel bleeder, uh, pericardial edges bleeding, and we should check the suprasternal area also. And in chest wall, we should mainly look for mammary bed, chest drain, and pacing wire chest wall entry points. So while closing sternum, we should also again look for periosteum, bone marrow, and sternal wire sites. So even after checking, if there is a significant bleeding, we should look for coagulation status. We should see whether ACT is back to baseline. If adequate protamine has been administered, that if hemoglobin is more than 8, if calcium is more than 1, if normothermia is achieved because hypothermia uh, decreases the coagulation cascade. If there is any suggestion of coagulopathy, we can do a test and we can see what is the issue. So, so after hemostasis checklist is done, we can do this 5-minute drainage assessment, which will prevent re-exploration when during sternal wiring and closure. So in this 5 minutes assessment, we'll measure the blood volume from one drain tube every 5 minutes. We'll reopen the sternum and do hemostasis if bleeding volume exceeds 20 ml. In ICU, if the patient is bleeding, you can look for coagulation profile. These are the investigations mainly done. If PT and INR is prolonged, it suggests extrinsic pathway coagulation factors deficiency. We can transfuse FFP. If there is increased APTT, it suggests intrinsic pathway coagulation factor deficiency. We can transfuse FFP. If there is any residual heparin action, we can give additional protamine. If fibrinogen level is low, we can transfuse cryoprecipitate. If platelet count is low, we can transfuse either RDP or SDP. If ACT is high, it suggests residual heparin effect. We can give additional protamine sulfate. If we are doubtful, we can do a TEG to look for functional assessment of clot formation. And if D dimer levels are high, it is a marker for fibrinolysis. And we can do a liver function test also. Liver makes the clotting factors, so liver dysfunction can worsen bleeding. This is the waveform of TEG. So in TEG, we mainly look for reaction time, K time, maximum amplitude, and alpha angle and percent lysis 30 minutes after maximum amplitude. So if R time is high in TEG, it suggests delayed clot initiation. That is, there is decreased clotting factors. So we can transfuse FFP. If K time is more, it suggests slow clot formation. Which means the fibrinogen levels are low. We can transfuse cryoprecipitate. If there is decreased alpha angle, it suggests low fibrin buildup. Then it suggests low fibrinogen value, and we can transfuse cryoprecipitate. If maximum amplitude is less, it suggests weak clot, that is platelet dysfunction, which can be caused by antiplatelets before the surgery, so we can transfuse platelets. If LV30 is high, this suggests hyperfibrinolysis, and we can give antifibrinolytics like tranexamic acid or aminocaproic acid. The following factors indicate that re-exploration is needed if there is torrential hemorrhage or increasing rate of bleeding tamponade, if there is hemodynamic instability, uh, and if there is large hemothorax in chest X-ray or echo, and if there is minimal coagulopathy. The key interpretation of study findings: re-exploration is morbid, but medically treated bleeding without re-exploration is even more morbid. Late re-exploration, more than 24 hours, has 14% higher 30-day mortality. The study supports yearly guided reoperation strategy to reduce morbidity. Past studies confirm more RBC transfusion has more morbidity and mortality. Re-exploration adds further risk. STS considers surgical re-exploration as a hospital quality and surgeon quality measure, but this may unintentionally discourage yearly re-exploration. Surgeon may prefer transfusion first, delaying surgery because re-exploration is included in surgeon quality measure as per STS. The study suggests substantial transfusion should also be a quality metric in STS. As we saw earlier, transfusion increased the risk of TRALI, increased mechanical ventilation time, increased rate of infection and sepsis. One RBC unit contained approximately 1 million donor leukocytes. So massive transfusion led to immune dysfunction, leading to infection and sepsis. Clotted blood in mediastinum can compress the heart, which can decrease the cardiac output and increase the venous pressure, which can eventually lead to end organ dysfunction and mortality. The bleeding definition and study limitations in this study. The definition of significant bleeding vary widely. Some define as greater than 10 units, including both RBC and non-RBC. BRC defines CABG related bleeding as any perioperative intracranial bleed, re-exploration, or 5 units transfused in 48 hours, or a chest tube drainage output is greater than 2 liter in 24 hours. So, strategy used in some centers: monitor high risk patients in OT for 30 to 60 minutes post closure. This allows yearly re-exploration before massive blood transfusion is needed. The limitations of the study: this is a retrospective cohort study. In spite of multivariable adjustment, patients in group 2, 3, or 4 may have had unmeasured comorbidities that contributed to their bad outcome. Group 3, patients who underwent only transfusion without re-exploration may have had reasons for not undergoing reoperation, which not which data we don't have in this study. And database limitations: there is no data on chest tube output, bleeding rates, or clinical decisions. Additional limitations: bleeding after cardiac surgery is multifactorial, might be due to coagulopathy, hemostasis techniques, use of antifibrinolytics. This study does not account for surgical technique differences, center-specific protocols, use of Rotem-guided therapy. The future directions: prospective studies is needed to define clear threshold for reoperation, compare guided re-exploration and massive blood transfusion. The final conclusion: re-exploration is morbid, but massive blood transfusion without re-exploration is even more morbid. Yearly limited transfusion reoperation may offer the best outcomes. Future guidelines should consider adding transfusion burden as a quality measure, standardizing re-exploration timing to improve outcomes. Similar study is done in our hospital in 2016 by Dr. Pratik Shah under the guidance of Sri Krishna sir. In this study, 217 patients were included from November 13 to 15. It is a prospective case control study involving 107 patients in each group. Patients who had CABG and underwent re-exploration were cases, and who were not re-explored were controls. So the result of this study is preoperative characteristics like age, sex, BMI, hematocrit, EF were similar between both the groups. Diabetes, recent MI, and anticoagulation use showed no statistical difference. Re-exploration rate is much more higher in on-pump CABG, that is around 79%, and compared to off-pump CABG, that is 42%. Average bleeding before re-exploration was around 871 plus or minus 357 ml. Mean Harley drainage in first 24 hours is around 87 plus or minus 37 ml. Average time to re-exploration was 7.4 hours. Surgical and medical causes of bleeding were almost equal in this study. IABP use was 6 times higher in re-explored patients. Low cardiac output was 5 times higher in re-explored patients. Mechanical ventilation time, ICU and hospital stay nearly doubled in re-explored cases. Comorbidities worsened if re-exploration was delayed more than 12 hours. The mortality in the explored group was around 11% when compared with control group, which is around 3%. Thank you.
Okay, Balaji, what did you learn from this paper?
Sir, we should have a low threshold initially. We should consider the patient for re-exploration without any significant blood transfusion, or if there is any hemodynamic instability, or if there is any increase in supports, then we should have very low threshold to take back the patient to OT during initial hours. If we delay re-exploration and it is associated with more comorbidities if we delay it more than 12 to 24 hours.
Yeah, this decision should be made by the operating team and not by some third person or somebody who's on duty. Because the operating team will know what difficulties or what are the problems that to anticipate and what are the causes of bleeding that could be there, because you have been inside and you know where you had difficulties during the surgery. So it is also the operating team is accountable for the outcome of the patient.
Yes.
So this is responsible, or at least if you are going to do this, you will have to, this has to become a routine. When you hand over the patient from the theater to the ICU, one of the senior residents has to go there and then explain what was wrong, what was happening, what are the concerns to the ICU team or the surgeon on duty, and then make sure that these things are followed. This has to become a routine. Otherwise, people will think, oh, we will just wait and watch and things like that. So we know that early re-exploration, sometimes it may be a negative exploration, which also can cause increased morbidity. But however, that is much less as compared to delayed re-exploration and massive transfusion. So the dictum is, when in doubt, look and see is not a bad idea. And the operating team should be involved with the exploration. That is something that you should all remember, because in Narayana it is okay because there are different people. There's an ICU team who's looking after the patient in the post-op, and then there is a whole lot of other people who are on call, who will take the decisions. So, but if you go out and you have your own patients, you're accountable for those patients. So you have to learn what to do and also have a game plan. Before re-exploration, you should know what to expect. Sometimes, very rarely, you will have surprises, but most of the time you can predict where the problem is and then go directly straight into that and then sort it out. So that is the message that you should know. And also then you have to have your own criteria for re-exploration. As Pratiksha's paper was okay, but she did not compare without re-exploration, massive transfusion, and this thing. She only took the re-exploration data. But I think that is fair enough to give you a good idea what to do and what not to do.
Yes.
Right? Yeah. Rahul, you have any comments to make, and are there any changes in the present setup? Rahul is there? He was there some time ago. No, he's not there.
Hi, sir. Good morning.
Sundar
Sundar.
sir.
Ah, Sundar. Okay.
Hi, sir.
Yeah.
I completely agree with you, sir. I'm a big proponent of number one, early re-exploration, and for example, the resident who, like for example, who's given the charge of closing the case and doing the hemostasis. So I usually ask them, was the patient dry or was the patient woozy? That's number one. And uh, if the patient was dry, and after shifting the patient, uh, if the patient is tending to bleed more than expected, then there is something wrong. Something is opened up, or there is one more thing which might be there is a lot of we give a wash, a plain saline wash. Sometimes we do not properly suck the pleura after that, just before closing the patient. So the initial 2 3 hours, they might have more bleeding. So the points which Balaji mentioned in his summary, that is hemodynamic instability, expecting if the patient is bleeding a little more than what is normally expected from him. Say, for example, the patient is a critical left main. We have not stopped his antiplatelets at all. We've taken him the next day. So the resident has to be aware of that, and even the operating surgeon. And so what you said, because there are different teams here in Narayana, sometimes a message might be lost. But then I think if we clearly communicate to the ICU, they get alerted very soon. So they start calling you up every 2 3 hours. Sir, the patient has bled 100. The patient has bled 150. Then it is up. The decision is up to the operating team whether to take the patient in or not. But if the senior resident on call doesn't have a good feeling about it, says because he was not there. For example, the on duty resident doesn't have any knowledge, even though it was communicated, because he was not part of the surgery. And if they want to re-explore the patient early, I usually tend to say to take the patient in early instead of giving many products and then re-exploring again late. So that basically once the patient starts bleeding, it's like a vicious cycle. You give products, the patient continues to bleed again because it doesn't stop. It's a surgical bleed, and always uh, it's um it's a surgical bleed unless proven otherwise, is what the dictum is. Unless you are extremely confident that all your suture sites are absolutely fine, first try to say that I might have made a mistake. Let's go in and have a look. So, and then that is, I think, a better way to go. Because after probably 24 hours, 48 hours, almost always there is a negative re-exploration. Even if there was a bleeder, that would have stopped, and and even just negative re-exploration is good because you remove all the clots. So it helps in collection, the patient not having collections post-operatively, then putting an ICD, all that. So
Yeah, that's a good point, Sundar. The other advantage is probably because you have been out of this system and then come back to the system. So you have seen what is happening outside. You have been responsible
yeah,
for your own patients, and so you have learned that. So that should be
yeah,
sort of inculcated with everybody here, so that these dictums. And then the other thing is what you rightly said was, when in doubt, you must rule out surgical bleed. So that is
yeah.
that is a very important dictum that all of you should follow. Yeah.
And sir, one few things which I've noticed with like the residents, I keep telling them when they're opening itself, each and every step has to be hemostatic, because you don't need to technically, when you finish the case, for example, all the grafting is done. And if I say, yeah, all the grafts are good, we look at the grafts, there's no bleeding site. Basically, you just look at the place where you cut and you sutured instead of trying to find new places. And that also happens when you do a lot of over dissection. For example, if you're doing a CABG, you just need to expose the aorta and the heart, and not unnecessarily dissect the fat which is in and around, and those places. For example, just the other day, Balaji, I told him in one of our cases, when he opened the case, and to not to unnecessarily expose the innominate vein, dissect the thymus over the innominate vein. These are certain small steps can be avoided, because those are, like, you have a lot of branches coming there, tributaries of the innominate vein. You need to unnecessarily clip them. Sometimes you might miss them. So, and now over a period of 2 years, when I was doing mix, now I've also noticed in you have to be much more thorough in mix, minimally invasive, because when you're doing the step itself, make sure you're extremely confident once you've cut, that place is not bleeding. So, yeah, I think the rule is the same, but probably a little more thorough in mix, because mix will not give you an extra chance. As
Yeah.
in, there is a high risk of tamponade there. Uh, of course, pericardial windows is now, I think Aradhana is doing the study on that, because that is making a pericardial window, whether it prevents tamponade or AF. As of now, the initial empirical results seem to favor a pericardial window, even in a thoracotomy and in a sternotomy, as of now. But yeah, these are few points which definitely help.
Yeah, I have reiterated exactly what you told to Balaji. So whenever you do, your first layer should be completely hemostatic before you go to the next layer,
Yes, sir.
Yes,
right,
yes, sir.
right from the skin down, right? And never work in a deep hole. Of course, now you have some
Yeah.
amount the scopes and other things, but never work in a deep hole, because you tend to get into bleeding and then cause problems. Yeah. These are few things
And
that
I've
you.
seen a lot of residents. Sorry, sir. I've seen a lot of residents not looking at the tip of the cautery. They have to always be aware of the tip of the instrument or the cautery, where the tip has to be absolutely visible. You cannot just blindly go beyond. And even while cutting the sutures, try to cut with the tip of your instrument, because you might, like, not. I know some instruments don't work, but don't go beyond that. So
Yes, sir.
Yeah. Any other comments, sir?
No, my only comment is actually what I've been teaching for a long time, maybe slightly old fashioned now. But basic thing we used to teach that there are mainly three indications for re-exploration after an open heart surgery. And conventionally, the re-exploration rate has been quoted between 3 to 6% or 2 to 5% in on pump cardiac surgery, whereas off pump cardiac surgery, it has been reduced so much, the world average has come to 1.78 to 2.8, 2.2. That's understandable because of the denaturation of the coagulation factors on pump, But then we used to teach that there are three main indications for re-exploration. One, continued bleeding. Two, uh, cardiac tamponade. Three, sudden hemodynamic collapse. And those days, continuous bleeding, we used to define as 500 ml in the first hour, 400 ml for 2 hours per hour for next 2 hours. That means 800 ml. 300 ml per hour in the next 3 hours. Or more than a liter of bleeding in 4 hours. That used to be the standard. If it is more than that, it's better to re-explore. The other thing, as Sundar said, it's most important to have a complete hemostasis before go on bypass, because it's important that every uh, point where bleeding may occur later on, because once the patient is operated and is coming back, he may be on vasopressors and those bleeding points may not be visible. That's very often the cause for a negative reexploration. So, spending 15 minutes or more on complete hemostasis before going on bypass and not unnecessarily dissect the tissues, you go directly to the point and then complete hemostasis under the sternum and wherever you open, not too much of dissection of the thymus. Just enough actually. That's one thing. Because I've seen a great surgeon under Dr. Cooley, probably one of the fastest surgeons I've seen. From skin incision to bypass is 7 minutes. On bypass for a triple bypass graft is 45 minutes. And then closure is 15 minutes. I've seen on my own eyes a skin to skin operation of a triple bypass graft in 1 hour 15 minutes. I'll never, I will never do such a thing. I think the time taken initially for good hemostasis is very important. I think that's one thing. The other thing is that in these three groups, I don't understand. I'll never. The group C, we have no re-exploration or massive blood transfusion. I think it doesn't sound uh, reasonable to me. And then I think somewhere you mentioned between the group 3 and 4, there's no statistical difference or something, which also I
Yes,
didn't
sir.
understand. Huh?
No, sir. Group 3 and Group 4, both group of patients had increased the hospital stay, more
Yeah,
complications.
for my understanding, group 4 will be much better for morbidity and mortality than group 3. Then the other thing, you say FFP is more likely to give trially, is it? Did I hear?
Yes, sir.
But don't you give a lot of FFP in our hospital?
Uh,
Hmm.
yes, sir. We give a copy.
Yeah. Which also I didn't understand very much why. How the you can either give pack cells or you can give a non-RBC transfusion cryoprecipitate or single donor and all usually not used in cardiac surgery. That's what my understanding is actually. What we usually do is pack cells or fresh frozen plasma. That's it.
Yes.
And also, if you use minimally invasive, actually the bleeding and re-expression is almost nil, not much. So,
Yes, in thoracotomies, we've noticed that the bleeding is extremely less.
yeah,
So that is one good advantage. So in a minimally invasive case, if you notice any bleeding which is more than what is usually expected, then it's better to re-explore early rather than wait for the
yeah.
patient to collapse and then end up doing a stenotomy and yeah, that is one thing. And definitely uh, su- suspecting one's own surgery and being critical of it is, I think, very important that we might have missed, and that is the first thing that will allow you to take the decision of re-exploring the patient early. As
Yeah.
Dr. Sri Krishna sir said, usually we get the usual culprits. It's very rare to find something bizarre. Like once we did, I mean, recently, I think 2 months back, I found completely something bizarre which I had not seen earlier. Is I operated on an old lady, uh, clean surgery, no issues, and suddenly the first hour she bled around 300. and that is what alerted me. And well, I was fortunately in MSH in the same campus, and Soumya went inside. Soumya was the resident on call, and she went to see. She said, "Sir, the drains are filling continuously." I said, "Is she hemodynamically stable?" And she said, "No, sir, she's hemodynamically stable." I said, "Okay, just stand there," because I was not expecting this patient to bleed at all. And then again, in the next half an hour, I think another 100 or 200 came in. We immediately took the patient inside. As soon as we took the patient inside, the patient started having hemodynamic disturbances. And once we opened the chest, we noticed that the lima was transected at the heel of the
Wow.
anastomosis. Now, I did leave an extremely long lima, as in it was, I grafted in the mid LAD. I dug the LAD side, so I grafted as proximally as possible. And yeah, but then some, I don't know, it was extremely bizarre. I was not able to understand. But the fact of the matter is, she had exsanguinated. Even though it was
Oh,
only 500 ml, which had come in the tubes, the left pleura was completely full. And by the time we opened the chest, took control, the pressures were around 50, and there was hardly any volume in the heart. I think almost everything had come out. So we had to go on an emergency bypass. But then the time taken from the patient being shifted to being shifted back into the OT, it was 1.5 hours. And from the hypotension to going on pump was probably uh, I think 6 7 minutes, because the- Soumya was in front of me. I didn't have time to take purse strings as well, because there was hardly anything in the heart. Like, for me to even cannulate, I had to put a Roberts. I just cannulate to hold the aorta for contraction, and we directly cannulated without the purse strings. She held the cannulas beautifully. The patient went home on the eighth day, but the thing is, basically, this happened, and I was shaken because I couldn't understand what had happened till the time I went on pump, because the patient was exsanguinated from somewhere. After going on pump, I searched for the vein branch, but the vein branches were fine. And then it turned out I couldn't find the Lima to LAD. And then when I put the octopus and then looked at it, I saw the anastomosis intact, and the neck of the anastomosis, that is towards the heel, and there was no Lima attached to it.
hmm.
It was extremely bizarre. And it was not like the patient's lungs were emphysematous, that it was pushing on the lima, and it didn't. So I never understood why it happened. But yeah, but then I think after that, I fix the lima at many more places than I usually do, uh, being even more careful. And if I have a small doubt that the lung might uh, 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 be overinflated, I usually fix the lung to the chest wall. Sometimes I don't do it in all cases, but wherever I suspect that happens. So yeah, like first hour was 300 ml, in the next half an hour it was 200. So we did not expect this bleeding at all from this lady.
Okay.
So I think in elderly also, like as his statistics pointed out, 68 years and more, they have a higher chance of re-exploration, because their tissues are different. And we have to understand that our patient's biological age is much more than the Aadhaar card age, which is there. So be very careful in handling the tissues as well. The risk versus benefit of trying to dig too much in a patient, where, say now I'm preferring to do a minimal access surgery for an elderly patient compared to a sternotomy. And as of now, empirically, I think it is help. I mean, I'm noticing that they do recover a little faster. I initially was apprehensive about operating on COPD patients using single lung ventilation, but now I've noticed if they're able to tolerate a single lung ventilation, asthmatics, so they tend to have a shorter post-operative course. I think from the last time I've come for this class and now, my learning curve, I think, has, like, as in, I'm a little uh, further along the learning curve. And I understand what Dr. Raghu says, that minimally invasive does reduce the morbidity in terms of transfusions, recovery. Pain, it doesn't, but in terms of recovery, they do have better results. So one more, so the most important thing is in mixed cases, in perspective of this class, if you feel that there is little more bleeding than what usually happens, please go in and have a look, because you won't get a lot of time in such patients.
Yes, sir.
And then the bleeding from the sternum, in the 1970s and 80s, you used to try the peristernal sutures, taking care of not going through the internal mammary artery because very often Transternal, the periosteum bleeds a little bit there, and actually the surgeon has to be very careful and take a figure of eight suture to control the bleeding. If you don't do that, your chances of re-exploration is much more. The other thing, the second indication for re-exploration, I said is cardiac tamponade, but it's very misleading. The cardiac tamponade after cardiac surgery is quite different from the cardiac tamponade in a cold case because very often it's a regional tamponade. A clot may be sitting on the LV, compressing the LV, preferentially producing cardiac tamponade. Number two, sometimes the SVC and IVC may be compressed partly by the clot. So that is what is called the regional tamponade. The other question to all the final years probably why there is no pulsus paradoxus in a patient post-operative cardiac surgery in the ICU. There will be no paradoxical pulse in a patient after cardiac surgery in the ICU. Why? We know the normal uh, diagnosed with cardiac tamponade is the backslide, hypotension, engorged jugular veins, and then muffled heart sounds. And another thing added is a pulsus paradoxus. Can you explain me what exactly is pulsus paradoxus? Why in a post-operative ICU you can never have a pulsus paradoxus? This is a question I've been asking for many years actually. Final years, no final years. Fourth years.
Karan is there. Who else is there? Karan, Krutika is there. Krutika is final year?
No, sir.
No. Okay. Karan, can you answer that question?
In a patient who's on a post-operative intermittent positive pressure ventilation, they can never, because what is the cause of paradoxical pulse? You know that it's a increase of what is a normal. If the
Yes, sir.
paradox is more than 10, that becomes a pulsus paradoxus. Up to 10 during inspiration, follow BP is normal. But what's the cause of pulsus paradoxus?
Anybody?
The- Sir, during inspiration, there will be increased venous return to right ventricle.
Very good.
RV bulges into LV, and then there is a decreased stroke volume. So there is a pressure drop in systolic BP. This is the mechanism of pulsus paradoxus.
Good. Good. That's one reason. The other reason is when there's deep
Very good.
inspiration, there's pooling of blood or the pulmonary venous blood into the lung. It's so the input from the pulmonary venous into the left atrium and the left ventricle is less. One is because of the too much blood coming to the right side, the ventricular septum may be pushed to the left side, so the volume of the or the stroke volume becomes less. The other is the pooling of blood during an inspiration into the pulmonary venous tree, the reduced blood coming into the left atrium and so because of these two reasons, the stroke volume becomes less. But that doesn't occur when the patient is on a intermittent positive pressure ventilator. That's what I. That's the answer for that. So actually, the other question they used to ask is when a pulses paradoxes may not be felt. The answer used to be one
Peric-
in the presence of a
Pericardium, we
yeah missed ASD. If that's a patient has got an ASD which you have missed, then cardiac tamponade does not produce the pulse paradox. Then, in a patient who very poor ejection fraction, the pulses paradoxes may not be felt. And fourth is the regional tamponade will not produce a. Okay. These are the basic questions sometimes we ask the students, for your knowledge.
So this question of yours is I was just thinking because Ibrahim is mentioned in his notes this question. So it is there in Ibrahim Institute of Cardiac Sciences, the notes which are there for the residents.
Okay.
So this question
Okay.
is there and with the specific points that you've mentioned. So
Okay.
the residents should go through Ibrahim's notes because
Yeah.
he's documented all our lectures very well.
Nowadays, nobody does that actually, In fact, what Krishna and I speak, that's forgotten next day. What we are
I
saying
think now they're
from a,
recording it, sir. Now
yeah.
they're all, I think, recording these
I don't know
lectures.
where it goes because we seem to be asking the same questions over and over and over.
But this is a very standard question of yours. So
So the take home message is dictum is quick in, quick out, do the minimum, achieve the maximum.
And then another thing, I'm saying about, some time ago, the about the reexploration in the ICU, emergency or elective. Because I heard very often Devi Shetty saying that a patient with a prosthetic or a bioprosthetic valve, if gets a cardiac arrest, don't massage, re-explore immediately. Is it? From my understanding, that's not quite true, but what exactly is the current practice, I want to know from Sundar and others, Because they many years ago when I used to come for the in a mortality meeting, there used to be a discussion of what to do when a patient with either a prosthetic or bioprosthetic valve suddenly arrest. There used to be an opinion that never massage, immediately reopen.
so that
What is
yeah, that
Morning to
conversation
Rahul.
started when I that conversation I think was there in 2013 when I freshly finished my ACLS BLS training
yeah,
in
yeah.
in AHA, and then I massaged one Dr. PV Rao sir's patient. He was POD 5, POD 6 post mitral valve replacement, and I was on duty. Dr. Sham was there as a consultant, junior consultant. By the time Dr. Sham came, they told me that the patient is arrested, so I gave a proper a proper massage, and then they took the patient inside, and it so happened that it seems that the mitral valve was not in its place, and
Tell me,
the
doctor.
discussion started, and there was a big
Sundar, I
uh,
have to come into this.
ha,
The joke was the mitral valve was vomited out by the patient because of the
yeah.
effect of
So
CPR.
yeah,
After
so
after Sundar's
then
massage, is it?
Yes,
yes,
sir.
sir.
After
After my
Sundar's
massage,
massage, the patient vomited out the
that is
mitral
what
valve.
actually, yeah, that is what that that is what initiated the conversation. But then the thing is, I didn't know better. I was in first year, and then they told me that the patient arrested. So I was giving a proper massage, like I was told, 100 compressions in a minute, 5 centimeter depth of compression, good relaxation between compressions, and all that. And so I didn't know any better. And then there was a big discussion in the mortality meet, which ended up between a fight between continuous and intermittent sutures rather than whether we give compressions or not. But then The point is, now we do give a massage when the patient is, even if there is a bioprosthetic or a mechanical valve, because we have an arterial line ETCO2 there. We just give adequate massage just because already the chest is very compliant, because we've already opened the chest and this. So we just give gentle massage just to maintain a little bit of map, probably around 40-50 map till, and we immediately take the patient inside the OT. So the massage is still given, especially in a mitral. Once we go inside, the internal cardiac massage becomes very difficult. So you quickly cannulate and uh, uh, go on pump. But yeah, with a mitral, even once you are inside the OT, it's difficult, like, because you massage and then you make the problem worse. Probably you might create a new problem like a navy groove injury. So there is a gentle massage and go on pump early. So that is the dictum right now.
That's exactly
There
my
are the
understanding, and my
excuse
opinion
Rahul,
is
yes, sir.
also like. Yeah.
One patient relative actually asked me this question on follow-up.
Yeah.
He said if somebody has a cardiac arrest post a valve surgery,
Mhm.
what should we do? So, like what Sundar said, when you have an arterial line, it is easy to give a gentle compression
Yeah.
and maintain perfusion. But in
Yeah.
out of hospital setting, it's a very difficult question to answer whether to give CPR or not.
Out of
So, what is
hospital
your
setting, if there is a out of hospital setting, if a valve patient arrests, and if there is a human being who is next to him who understands cardiac massage itself, is a bonus.
true? So, I think we should let them massage because that is the only chance he'll have, either which way.
Yeah,
That's what
exactly. Yeah.
that's what I also think. That is not absolutely contraindicated, but gentle massage to get a pressure of 40 or 50, that's enough to survive and brain circulation. So the
Because
dictum that
anyway, the
never
patient is on
massage,
100% FiO2.
yeah.
The other point of Sundar, I completely agree about elderly patients with the mix.
Yeah.
I think it's a paradox, but most of the elderly patients do much. They benefit more than the younger people. If you prepare them well before surgery, they do much better post-op. Less bleeding. Uh, they go home faster, and it sounds a little odd, but actually it is practically true. Even in my experience, all of these old patients, 178-year-old went home on day 5 comfortably. So I think I totally agree with Sundar on that. So
Okay.
minimal access is not for a show. It's actually helps in a lot of patients, primarily for preventing sternal wound infections, but also probably the recovery is little better in elderly.
The other patient that you mentioned, Sundar, the Lima transaction, that is an exceedingly rare thing, rare phenomenon. We have not heard that before. This was not
Even I have had an
presented.
experience like that.
This was not presented in the mortality meeting.
Sir, the patient survived, went home, sir. The patient.
Yeah, but it should have come and that's why I keep on telling people, just say re-exploration,
Yeah.
bleeding, and then there's this thing. Well, there are a lot of things that happens with re-exploration, why it happened, how it could happen, sort of things.
Correct.
These are
Sir,
this is
most
a very important learning curve. I mean, learning lesson, and I think you should publish this
yes,
as a
sir.
case.
So I'm
As a case report, you should publish this.
okay, sir. Done. Because, and sir, one more thing, that the residents, for the residents, they can't just keep saying general losing all the time. Even I've noticed,
Exactly.
even in my patients who have been re-explored and there is a positive re-exploration and we found the bleeder, I've noticed the next day Dr. Sanjay telling me, so was it a general lose? I said, no, sir, they found the bleeder. No, but then it was communicated that it was a general lose. So they have to be truthful and then mention the reason for
And
re-exploration and like, I mean, this is also for documentation sake, so that if we do end up doing a study on our patients, which we exactly know why the re-exploration happened. uh,
exactly.
yeah.
And I also
Sundar, the
insist
problem is
on the
also in
resident.
the
I also insist because it is for their learning. Who was the resident who closed? Who was the resident who did the Lima harvest and things like that? They can't just say Lima or Lima bleeding, Lima bleeder, and things like that. You see, this is a learning curve, and you should know from your mistakes so that you don't do the same mistake again. And re-exploration is not a simple thing that should be just passed off and only discuss mortality.
Yeah, that's true, sir.
That is
Rahul, you were
what I.
saying something.
no,
Yeah.
regarding Dr. Sanjay telling you about the thing. I think that is
Okay.
a separate problem because of the handover in the ICU. You would have seen the notes in Adi how mitral valve repair becomes mitral valve replacement from the one ICU resident writing the notes. Then MVR becomes DVR. That problem is a different
No,
set of problem. But
no, that's
like
true. But
in
at
the
least
ICU,
once we
yeah,
we can like now there is this. I think I'm in love with this EMR because there is after this OT notes there is something called perioperative
area of
column,
complications. Yes,
peri-op
correct.
complications,
Yeah,
where you can mention that. And I don't think,
yeah,
yeah, I think we are absolutely medico legally safe also to mention it because there is nothing wrong in saying that there was a problem. We took
yeah,
the
yeah.
patient inside. We took care
I
of the problem. Yeah.
I mention it for all my reactions, even that
Correct. Correct.
what sir is
Yeah.
mentioning is about that MVR which had a problem. So we made
Okay.
sure we are documented it in the peri-op complication, taken back,
Yeah.
re-explored, went on pump, all that. So everything
Yes.
was detailed in that.
Yeah. So I remember one MV repair patient of mine, my second only MV repair, had a lot of issues. We kept the chest open. Patient was in low cardiac output. Then on POD 11, suddenly he had a hypotension. He was still in the ICU, but not on tracheostomy. The next day they were planning to shift him to the ward. Suddenly he had hypotension. The supports went up, which were not there from before, and we saw the chest x-ray. There was a whiteout on the right side, and it turned out to be that the patient bled from somewhere, but we on POD 11 we re-explored him. Again, he was there for a few more days in the ICU, but fortunately he went home. But then we removed the clots. So basically it's these secondary hemorrhages which happen also require early intervention. So uh, that is also there because after that, after starting supports and he had stabilized, but then there were already whatever bleeder must have there was a bleeder which would have been there, which would have stopped later. uh, I didn't find the bleeder because there were a lot of adhesions on the right lung, but we gave a wash. I think that so an elective re-exploration is very important because the sterility is maintained. So that is one of the most important things. So you take a decision early for a re-exploration. You have time to paint, drape, take all the sterile precautions as you would in a normal case, which would not happen in an emergency. So you're definitely the infection rates would come down. In So just to worry about not taking the patient inside because infection rates may increase, I think it's if you take it early, then you have a chance to do everything sterile in a good as you would do in an elective case. So I think the word elective re-exploration I think is a very important term because that would reduce the rate of infections as well.
That is Dr. Praveen Kumar's dictum. He always prefers a negative re-exploration rather than waiting.
Correct,
He would
correct.
say, you take in, even if you don't find anything, I don't have a problem. But if you
Yeah,
have a doubt, take in, sort it out, and get him back
correct,
rather than wait on
exactly.
it.
Yeah,
Okay, I think this discussion can go on and on and on. I think we'll wind up here. Thanks everybody. Thanks, sir.
thank you,
Thank
sir.
you, Sundar and Rahul, for the